Great. Thank you. So everything you ever wanted to know. So I'm going to start off with what the mission of the residency is, just so we all understand that. It's to train competent surgical leaders with a clinical, research, and education focus. All right, so that's kind of the context that I'm putting this all into. But really what we're doing right now is we are going to look at the residency through the eyes of the RRC, through the eyes of the health system and the School of Medicine, through our own eyes. The ACGME and RRC will ask you, both residents and faculty, questions about the residency sometime in the spring through a resident survey. Many of these things that I'm going to talk about here today, you may hear again on that survey, so they're important to know. When we go through the slides, I'm going to show you what the response rates were for some of these items, which I tell you about every year, of how well we answer yes to, yes, we do these things. So it's really a hodgepodge of things. Also incorporated in this are some practical things that the residents need to know. And there's things that are incorporated in here that I think the faculty need to know that you might not be aware that we actually do. So this is going to be a variety of different things. Number one, as surgeons, you are the captain of the ship, regardless of if you're the chair of the department or if you're the first day intern. The only difference is the ship that you're sailing is a little bit different in size. But you're still the captain of the ship, you still have responsibility. This is a great idea in terms of what it is to be that surgical leader. You are the one out in front doing the thing. So there is no task that is beneath me, right? Which means that there's no task that's beneath you as the resident. So there is no reason why I shouldn't be necessarily the one that can go into a patient's room and change the dressing or cut out the suture or do the follow-up phone call. The same applies to the chief resident. There is no task below you that you should just be like, that's not my responsibility. I'm going to make the intern go do that. You might have the intern go do that, but you are the one that has to assume that responsibility. You need to lead with example. I don't know is sometimes the most honest answer that you can provide. We will take that over the wrong information any day, any time, and I think all the faculty is going to agree with that. It's not always easy to do what is right. That phone call at 3 o'clock in the morning to go look at that patient, to get yourself out of bed, get into your car, drive into the hospital is difficult, but it is what we have to do, and it is why we've gone into what we do. I always like to say residency, there's a mentality to it. There is the equivalency of falling back into high school. That is what, as a resident, you have lockers, you bring book bags to work, you eat in a cafeteria, you hang out with your friends, you move along in classes, you eventually graduate, very much like high school. The problem is we're not in high school. This is a professional environment. You need to behave professionally. Every one of you has someone that looks up to you. Even the first day intern, you have medical students that are looking up to you, watching everything that you do. It's like being a parent with kids. You don't have to tell your kids necessarily what to do. You just have to behave in the manner that you want your kids to behave, and that's how they will act. Same thing goes for residency. If you want your junior residents to do well or your medical students to be good junior residents, just play the part and they will follow your lead. Your patients certainly are counting on you. There are good and bad examples throughout residency of the mentality that works and the mentality that doesn't work. So the always complaining, always saying, gosh, this is so horrible. Why do we have to do this? I can't stand going to the clinic. That gets translated down to junior folks. And they say, well, my senior doesn't like to go to clinic. Well, then why do I like to go to clinic? But if you have a positive attitude of, there's a lot to learn from clinic, you need to know that pre-op workup, you need to see what happens to your patients, then that translates over as well. In case any of you don't realize, you are going to make a lot of sacrifices in your life. You're going to make a lot of sacrifices to this profession. You are not going to attend every wedding that you're invited to. You're certainly not going to attend every birthday party, and you're probably going to miss some big events because you've chosen to be surgeons and not bakers or someone else that even bakers work a lot. You don't have the typical 9-to-5 job where you can say, I have this day off, and that's the way it's going to be. So what you can do, though, is as part of a team, you can help others alleviate some of that sacrifice. So, hey, I know you have this wedding to go to. I'm more than happy to help cover your call that night. So you're able to go to the wedding, and we balance it off, and that's sort of what being part of a team means. So some practical pieces. Part of staying in the professional leadership mindset is making sure that you dress the appropriate part. As a residency, this is the dress code that we adhere to. There are things that you can wear and things that you cannot wear. So you should be wearing a white coat. You can wear scrubs, but as I was reminded the other day when I saw a chief with ripped scrub pants up their leg, your scrubs need to be in good condition. They can't be ripped. So scrubs are appropriate. You can wear the black North Face jackets, but you can't wear any other jacket. All right, it's only the black North Face jacket because it keeps uniformity amongst the team, but you can't just wear any black jacket or somebody with a non-black jacket. I mean, that's part of the attire. Or you can dress in a business attire. I think everybody knows what business attire is, but you can dress in business attire. I don't have it because it's sitting on my desk. Everybody needs to have their name badge visible regardless of what you're wearing. All right. No hoodies, no iPods in your ears while you're walking through the hospital. That just irks me to see you walking around with your iPod tucked in your pocket and one earphone in your ear. That does not portray a professional attitude, and that's not part of the accepted attire that we have. Also, no open-toed shoes. That's not a residency thing. That's a OSHA thing. If the residents in the room don't know, eventually you will spill something on your feet that you do not want ever to touch your feet. Do not wear open-toed shoes. Patient lists. Everybody has them. Bet you we show of hands. Everybody in the room has a patient list. This is an invaluable document that is exceedingly important. That is to only be in your pocket or in one of those disposable waste bins. The approved disposable waste bin. It laying on a desk in a call room, or it laying on a conference room table, or it laying in your car is not appropriate. The worst thing to have happen is have your car stolen with a list in it. So as bad as getting your car stolen, that's bad. Having one of these patient lists in your car when it gets stolen, even worse, because it has to be reported to the hospital, and now you have a HIPAA violation because all those patient information that's protected has now been stolen and you have no idea where it is. The person who prints the list is whose name's on the bottom of the list. They will ultimately track those lists that are found around the hospital back to you. Only print enough lists for those that need it, and make sure that those lists get disposed. Don't leave them laying around in the call rooms. QI. Surprisingly enough, only 96% of the people that answered the survey last year thought they participated in quality improvement. Not sure what you think quality improvement is, but what we just did for the last hour is quality improvement. Everyone participates in it. Everyone should answer yes to the question of, do you participate in quality improvement? You will hear, Dr. Jerkovich has made a push that we will, on the 5th Tuesday of the month, you will even hear more quality improvement information. The different divisions will be presenting quality metrics to you in what we track within our own specialties. So Dr. Cook and I will tell you about TQIP and STS in the end of August to review quality improvement. That is a key factor. Does everyone participate? Yes. That's the most important thing. The way M&Ms work is the divisions need to track their numbers. We're going to continue to put up the data up there, each M&M, for how many cases you did, admissions and discharges. The chiefs need to sit in the front of the room. The front of the room is the first 2 rows. Ben Keller, 2 rows. This is actually counts as front of the room. But every resident should track their complications. You keep a list of cases, meaning you should track what happens to those patients in terms of cases so that you're able to go back and see what your practice pattern's like. There's a question on the survey that may ask, are you provided information with your habit of practice? That is not easy to obtain because I can't tell you sometimes what faculty's habits practices are. You need to track your own practice data and you need to know your own complications. Your complications within the division from the RRC need to be reviewed. They need to be reviewed at a division, and if they're not reviewed at the division level, then you need to seek out Dr. Jerkovich because complications that involve residents need to be reviewed by someone prior to big M&M. We are going to have a presentation over the next month on a new process to track M&Ms, which hopefully will make it much easier for you to track and get data for M&Ms. It's called QView. Stay tuned for when we do that presentation. Interprofessional teams. 99% of you said that you do work on interprofessional teams. That's a great improvement from the 70% that said it the year prior. But you work into these interprofessional teams are not just doctors, but they're nurses, physical therapists, dietitians, pharmacists, everyone that goes into the care of the patients. I think that everyone would agree you all participate in interprofessional teams. So unprofessional behavior, this is, part of it is perception, part of it is reality. I mean, there's gross evidence that you can, yes, everyone agrees that this is unprofessional, but if a patient perceives you as unprofessional, then inherently you are unprofessional. It is intertwined in everything you do. So it goes from everything from how you answer your page back. When you answer a page back and you just give your service name, that's sort of not in the professional. This is Dr. So-and-so returning a call from Division X or Service X. Not just, I'm Trama. That doesn't set you off on the right foot. The other thing that doesn't set you off onto the right professional foot is when you do a consult, then you never tell anyone what your consult actually recommends. You should follow up with the person that called you to say, hey, I saw that patient you asked me to see. These are our recommendations. Here's how we would proceed. That builds those relationships that are going to be key. Other things for professionalism are hand washing and observing the isolation precautions. So I'm just going to quick pop into this room. I'm not going to wash my hands, and I'm not going to down this gown just so I can say hello. I understand the air might not have the bacteria on it, but professionalism is you adhere to the rules that are out there. The rules are you wash your hand between all the patients, you put on the gown when you need to. So as I said, perception is reality. The health system has identified essentially 7 deadly sins. These are things that when they come up that we encounter from a residency standpoint, I as a residency cannot independently handle. I have to forward on to the School of Medicine and the Dean's office, and they will take care of these issues out, and it's outside of the residency's hand. So the first thing is, if you don't adhere to the standards of care. So we do provide great care here at UC Davis. And part of that care is protecting patient privacy. It is patient privacy, as I mentioned with the lists, goes from everything. So EMR, if you want to have a short career at UC Davis, look yourself up in EMR. So do not look yourself up in EMR. Do not look up your friends in EMR. Do not look up some famous patient in EMR unless they're actually under your care. That gets tracked, and that will make your lives here very short. Remember patient privacy. A lot of places where you take care of patients are separated by a curtain. I don't know about many of you and your experience with curtains. They are not soundproof. So be careful about that sensitive conversation you're having between curtains. The worst one is be careful when you're signing Mrs. Smith out of the clinic and you're at the front desk and you're saying, Mrs. Smith needs to have this problem taken care of and needs to have a bowel prep because we're going to do this and that. Mrs. Smith doesn't need the entire waiting room or the entire clinic to know what procedure she's having while you're trying to check her out. So it just means you have to adhere to that patient privacy. You need to be at your best. Be at your best means if you're going to go out drinking at night, make sure you stop drinking early enough that you don't show up to work still intoxicated. That applies not only to drugs and alcohol, but it also applies to sleep. Make sure you're well rested when you come to work. You need to be at your best. There are many programs here at Davis to help you if you run into problems with drug, alcohol, or depression or anything else. Maggie Ray's number's up there. Maggie Ray sees 30% of the residents in the entire health system every year, available for drop-in appointments or scheduled appointments. And then Dr. Yellowis runs physician wellness and is very open to helping residents at a moment's notice. Remember, UC Davis stuff belongs to UC Davis. The couch in the call room might look good in your house, but you shouldn't move it from the call room to your house. So don't take things from UC Davis. That will generate quite a few issues. Professionalism, your work is your work. You shouldn't use someone else's work as your work. This is typically with publications, but it happens every day with EMR. If you didn't do the physical exam, don't cut and paste someone else's physical exam and put it into your note. That's just unacceptable. Once they get that you are cutting and pasting, certainly when you cut and paste the wrong thing. So someone cut and paste, the amputation was on the right and the patient had an amputation on the left, and that was perpetuated through the note for weeks at a time because people kept cutting and pasting the note. The new EMR system is going to change it so they track where all of your cut and pastes came from in your note. So that should eliminate that process. You're all very good, but no one's the greatest. You should never physically try to restrain, tackle, chase a patient. All right? So if you have a patient that's being belligerent, you have a patient that's trying to make a break for it, you need to call the police and have them take care of it. I don't care how good you think you are, martial arts or whatnot, you're not to physically go after a patient. Even Dr. Brown should not go after the patient. Either one of the Browns. Everyone here is equal, so not only is it physical, but no harassment or discrimination of patients, staff, other residents. That is dealt with very severely. In essence, for professionalism, this is all the patient sees of you. You can do the greatest operation in the world. What do they know about is what the scar looks like. The other thing they know about is how you're behaving when they see you in the hallway. And don't think that patients only see you when you walk into their room and they're in their bed and you talk to them there. Patients and their family are all over this hospital. They see you in the cafeteria, they see you walking down the hallway, they see you in the elevator. Once you walk into work, you need to assume that your patients are seeing you all the time. So the RRC likes us to tell you what the program's effectiveness is. This is the program's effectiveness for the last 5 years. It's all tracked in 5-year increments. 100% board pass rate for the written boards, 87% pass rate for first-time orals, overall 100% pass rate. Oral boards and written board pass rates are a little bit sketchy. If you don't take them in a year, it counts as a fail for the program. It doesn't count as a fail for you. It just uses up one of your years. So when you see these numbers, sometimes you have to ask yourself, did everyone actually take the oral boards this year or not? So when you look at the programs in California, we're the only ones that have the 100% board pass rate, other than the Navy now has it, and we are in the top 3 for the oral board pass rate. No one is at 100% for oral board pass rates in the state of California. If you want to be involved, you can become steering committee rep for your class. You can come to class meetings. That's important. You will have fall and spring reviews with representatives from the residency where we'll review your performance, go over the RRC requirements, and talk about whatever you have. Surprisingly enough, people don't like to raise concerns because 9% of you are fearful of retaliation because if you raise concerns. I find that hard to believe. I do think that you, after the roast this year, that you do think that I'm a little bit scary, but I don't think that you should fear retaliation for bringing something to our attention. In fact, just give it to your steering committee rep and let them bring it to me. There should be no fear for retaliation. As those of you that know, we have and are continuing to participate in the first trial. This is the flexible duty hours in residency training. We are in the flex arm, meaning we have to adhere to the 80 hours per week max for duty hours. You need to have 1 in 7 days off averaged over 4 weeks, and the RRC defines 1 day as a 24-hour period. It's not a actual calendar day, and no more than every third night call in-house averaged over 4 weeks. They're the duty hours that you need to remember that we adhere to. These are the first trial results. Basically, the two arms, when they showed minimum time required, the different shifts, the different duty hours, all maintaining 80 hours per week, no difference in patient safety or resident well-being. There was a little bit of a trend towards residents who had the flexible hours to not have as much free and personal time. That's somewhat understandable, but there was not anything that was significant that said otherwise. The first trial is continuing at least for another year as they continue to acquire more data of what the longer-term impacts are with flexible duty hours. So, surprisingly enough, 80 hours average, and that's averaged. Remember, you could work 120 hours 1 week, but only 93% of you think that you adhere to the 80 hours. We're adults here. I expect everyone to adhere to 80 hours. I can't track all 70 plus of you to say, oh, you're at 81 this week and you were at 80 for the past 3 weeks, you're going to go over hours. That's your responsibility to track your hours for the 80 hours. We make the call schedules to not violate the other hours, but the 80 hours is really on you. In-house call, as we mentioned, night times, you can't work more than 6 nights in a row. So if there's a shift that you're working, let's say the ER, trauma shift, you can't do more than 6 of those in a row. In fact, we set the call schedules up for 5 of those. 1 in 7 days. At-home call does not adhere to these rules. So at-home call, you could do at-home call every day of the week, 7 nights, as long as you have 1 day off. But at-home call, the only restriction is it can't impact your personal wellness. Not really sure how that's defined. It's probably defined a little bit differently for everyone, but can impact your personal wellness. I need your duty hours to be updated on the first 15th of every month, and I need it done in echo time. In a week, I will pull someone randomly to see if their duty hours and operative case logs are up to date. If they are not, their chief won't operate on the service until the entire team of that service has their administrative work complete. All right, so I'm giving you fair warning now, and we'll pull that name shortly. Education over service. 87% of you think education outweighs service. This is key, is to define what service is. Service is anything that a physician does not do. Discharges, H&Ps, writing notes, seeing patients, going to clinic, doing small procedures, that's what a physician does. That is part of the education. That is not service. Service is, do you push a patient from upstairs, downstairs because there's no transport? Do you have to go in and get all of your patients out of bed? Do you need to go around and draw all the labs in the morning? That is service. There might be some education in some of that, but that is what the RRC considers service. So when you're asked that question, you need to think service versus education. Everyone can't sit in a lecture and everyone can't have someone standing next to them teaching them 24 hours. That's not the way surgical education is designed, but service is truly separate from what we do in terms of education. Supervision, 98%, 96% of you think that you're adequately supervised. You're not alone. There's someone always here. There's always a backup. All of your services have backups. And the most important backup is everybody has an attending that's responsible for those patients. They are your ultimate backup. This is a practical piece. So we know that you need to go on leave sometimes. We know that you need to have schedule changes. The quick, easy summary for this is anytime you're not going to be able to adhere to the schedule or you need to go on leave, myself, Dr. Humphreys, the house staff office, the chief of your service, and the more senior residents on your service need to know that you're not going to be here. And you need to get approval before you go. For the ABS, it's if you are gone for more than 48 hours, you need to report that on your board application. So you need to be very careful in saying, I'm going to take my weekend off this weekend and then I'm going to be gone next week to go for interviews. Well, the board needs to know about that, and that starts to tick off on your number of weeks that the board requires, meaning if you do too many of those, you're going to have to owe time back, not to me, but to the board at the end of residency. And the board is very strict down to the day in terms of what they count for being able to get admission to those exams. You can't take time now and hope to repay it in the next rotation. You either repay it in this rotation or you repay it at the end of the year. There's no repaying 2 months from now for time away. It just doesn't work out, partly for how the board wants it reported. As I said, any travel requests that you know about ahead of time need to be reported within greater than 30 days of the travel, or you might not get approved to travel. The only exception are when it comes to interviews. If you have interviews that you don't know that are coming up, that you're offered at the last minute, those we have to make exceptions for. But conferences, most conferences tell you more than a month ahead of time that you're presenting at the conference. You need to tell us. Without that 30-day notice, you might not be eligible to get the reimbursement or time off to go to the conference. Any planned absences, you need to report to the attending of the service and to the chief resident and other residents on the service so they know ahead of time, not the day before, that you're not going to be there. If you want to change a block or the call schedule, you do all that through the chief residents. Make sure you tell the chief residents, whatever resident you're changing with, Dr. Humphreys, myself, and the house staff office, so we can make all those changes. Otherwise, you're responsible when your name pops up on the call schedules. Things do happen where you can't come to work. Family emergency, you're sick. Keys to that: number one, during the day, even not during the day, obtain all of the information you need. Your grandmother's sick. I'm sorry about that. You're going to leave. You should tell us, you're going to leave today on this flight. You're going to come back on this day, on this flight. You're planning on being gone for this number of days. This is what's happening. As much detail as possible, because we need to plan to help cover that. Talk to your team, see if they can help you out to cover your time while you're gone. Make sure you page Dr. Humphreys if it's during the day. Don't page her in the middle of the night to tell her. Just send emails if this is at night. But page the chief resident on your service to tell them that you're not going to be here tomorrow. If you leave and don't tell anyone, that is extremely serious and it will be dealt with harshly. I cannot have people just not showing up. All right, it'll be treated as not showing up. If you are on the schedule, you're expected to be here. I need to account for your whereabouts if something should happen, and I account for your whereabouts based upon the call schedules. I don't care where you go on vacation. I don't care where you are on your days off. I care when you're on the schedule. You have to be here. This is just a list of administrative responsibilities. Administration is now part of the milestones, so you all get graded on your ability to follow administrative tasks. These are the administrative tasks that you have: monthly case logs, update it, service evaluations at the 2 weeks after the rotations, your duty hours. Don't forget to sign your verbal orders. Remember, you only give verbal orders if you're in an education conference or if it's in an emergency. Otherwise, they're not supposed to be taking verbal orders from you. That's hospital policy. The other thing is make sure that when you discharge a patient, that you do the discharge summary and get it to the attending within 48 hours. Attendings are getting tracked on filling out discharge summaries, and sometimes the patients don't have discharge summaries when they leave on Friday night done until Monday. You have to get those discharge summaries done. 91% of you participate in scholarly activity. Everybody, this is not mandatory within the residency. Everyone is assigned a mentor. The faculty are here because we enjoy doing research and doing academic work. It is not just doing a study, but it's also doing a case report or writing book chapters. So I encourage anyone that's interested to pair up with either your assigned mentor or an identified mentor and work with them. I would expect that the mentor-mentee relationship is such that when you're assigned to a mentor, you meet with them twice a year. This is not to evaluate your performance, but to help you with career guidance. You can change your mentors after a year if you don't like who you were assigned. We understand that. And we know that people have multiple mentors. So don't think that your one assigned mentor is the only mentor that you can have to help you with advising you of how you should move through your career. But we do provide mentoring. Surgical Research Day. Encourage everyone to apply and submit abstracts for this. If you remember, we had great turnout this year, both podium and quick shot presentations. Gives you a great opportunity to practice your presentation skills. It also gives you a chance to highlight to the department all the great things that you've done over the years. We also, when you work with UCD faculty, allow you to travel to conferences. We give you the time off to go. We give you a $1,500 stipend to cover some of the costs for the conference. I know that that doesn't cover all of the costs, but it covers some of the cost. In order to get that $1,500 reimbursement, in addition to your receipts being turned in within 5 days, I need a manuscript turned in within 5 days. Doesn't have to be the final draft, but I need a manuscript that's written to be turned in to get that money. You're all guaranteed one of these trips a year if you do get accepted at a meeting. This is if you're presenting as a poster or a podium presentation. Alaska and Hawaii are negotiable. This does not include international travel. That has to be PI funded. So whoever your faculty mentor is has to give you, I can't give you the money to travel internationally. I do encourage you to apply for scholarships. National organizations always offer scholarships. Apply for scholarships. Even if you get a scholarship and you're not presenting at the meeting, I'll still let you go and count that as an educational opportunity because it is admirable that you took the time to apply and you won the scholarship. So, in terms of outside educational activity, PGY 2s and 3s are allowed one outside educational activity. It means that you are given time to go to a meeting. I'm not going to pay for you to go to the meeting, but you're given the time off to go to the meeting, and you're allowed to go to one as a PGY 4 or 5. That's examples would be you go to the SAGES basic course as a 2 or 3, and then you go to the advanced course as a 4 or 5. Surgery school, 90% attendance requirement to go to surgery school. You don't have to attend when you're on Graves, at David Grant, or on vacation. Otherwise, every other service you're expected to attend surgery school. Make sure you sign in. That's key. That's how I track your attendance. But more importantly, you should not have your service pagers in surgery school. Those service pagers need to be offloaded to the faculty or the division or somehow handled so that you're not being interrupted during surgery school. Meaning all of the divisions and the division chiefs need to have a mechanism for who's holding that pager while the residents are in surgery school. This is a key RRC requirement that this time is protected. I'm not going to track you down to say who has a pager and who doesn't. I expect that you assume that responsibility on your own. ABSITE, everybody knows about this. January, everyone takes the ABSITE. Suggest that you start studying for that. Part of the studying is just reading and studying in general, not studying specifically for the ABSITE. You need to have over a 35th percentile on the ABSITE to not have a dedicated faculty assigned to you to help you do better the next year. And then every spring we do mock oral exams with the chiefs. You're expected to attend this. We will give you the date well in advance. Do not schedule things on that day. If it is your vacation block, I highly suggest that you try to be here for that day, but I don't mandate it if it's during your vacation. I need to tell you about a handout format, a handoff. This is the way you're supposed to hand off all patients. This is a question that people will ask when they come for the clear site visit. Were you given a dedicated handoff format? This is it. Domain, you give the diagnosis, the operative plan, any medical problems, any anticoagulation, incomplete labs or imaging, anything that you haven't discussed yet as part of the overall patient, and what needs to be done. Evaluations. 96% of you think evaluations are confidential. They are extremely confidential. No one sees those evaluations. I review the evaluations. I can't review mine, so you don't have to worry about that. I don't get to see mine. I review all the other faculties. Then I batch them in a 12-month period and send them to the division chiefs anonymously. So it's not just who was there for this year, but it's evaluations from people from last year, so that all of those are confidential, but you have to provide some feedback to the faculty. Your evaluations of the faculty and theirs of yours, no one else sees theirs of yours except for you. Learners, 89% of you thought that there was no interference from outside learners. 11% of you think that there was interference. There's been some changes, so we don't have as many San Joaquin residents rotating here anymore. We don't have as many ortho and ENT residents rotating with us, so the number of learners should have been reduced for this upcoming year. The faculty are here to teach. That's what we like to do. That's why we're here, even though 9% of you think that we're not. Conferences, we kind of already talked about those. Required to be here at M&M and Grand Rounds and at surgery school. Even if the attendings have cases on your service, guess what? We can operate by ourselves. Don't feel bad about leaving us by ourselves. 96% of you have been provided education for sleep and fatigue. This is sleep and fatigue education. This counts. I'm going to give you some quick slides. That you fell asleep because the conference is boring, that's a myth. You fell asleep in conference because you're overtired. All right? It does impact professionalism, so you need to be on your best. Remember, I mentioned sleep as part of one of the reasons for professionalism. These are warning signs that you are extremely tired. You fall asleep in conferences, you're irritable, you have to check your work, your difficulty focusing, you just feel like you don't care. That's like card and post call. So you got to go back and sleep. If you keep doing that day after day, day after day, it's going to impact your performance. Napping, there's pros and cons to napping. They give you an adequate burst of energy. You can do it preventively by doing it pre-call, or you can do it operatively by doing it while you're on call. I need to tell you, I encourage you all to nap between the hours of 10 and 6 a.m. That's an RRC requirement that you should do strategic napping. Don't nap for more than 30 minutes unless you're going to sleep for 2 hours. Yeah, naps don't replace adequate sleep. How to survive your night shift. Make sure that you get adequate sleep when you're at home sleeping. It means dark room, earplugs, eye shade, whatever you need to be able to sleep. Nap before you go to work. When you're awake, try to get bright light exposure. Don't get bright light exposure when you're trying to go to sleep. Fatigue, this is part of sleep. I know you're going to be fatigued. As I said, between 10 and 8 is what the RRC, 6 is when rounds start, so I highly doubt that you should be napping between 6 and 8. But If you are too tired to leave, I can provide you with a taxi voucher to get you from the hospital to your house. I can't provide you a taxi voucher to get you from your house back to the hospital. All right, so the GME provides you one-way taxi vouchers. We also have call rooms that you can use during the day if you're too tired to sleep. You can sleep in the call rooms. This is not only applicable to this site, but it's all the sites that you rotate at have call rooms that you can sleep in during the day. Fatigue mitigation, I'm too tired, I'm on call, I can't adequately take care of the patients. This policy says you can contact the senior resident or attending. You can tell them that you're too tired, you're unable to safely care for patients. They are to assume your patient care responsibilities and the pager right away. You are to go sleep on site, not get in your car and drive home. Once you're adequately rested, you can then go and take back the pager and be ready to go again. OR cases, I'll send this out, but remember, these are going to change for next year. For this year, it currently is you need 750 cases to graduate, 150 in your last year, plus 25 TA cases. You need to meet all the cases in all the defined categories. You can't selectively choose some categories not to meet. You need 75 as a PGY1 and 250 at the end of the PGY2 year. The PGY2 year can be surgeon junior, first assist. It can also include procedures like central lines and chest tubes. Those don't count as defined categories. This is the list of procedures. You need to be signed off to be competent to perform these independently. It takes about 3 years to check off everything on the list. You will see there's going to be a big push at the hospital level that this is all tracked through eValue, and the nurses will be able to pull up in eValue if you're competent to do a procedure or not. So if you submit a procedural competency to a faculty and want them to check it off, be sure to follow up with them to check it off, because you might think that you're signed off and ready to go. They didn't complete the evaluation, you're not signed off. Nurses will check and they won't let you do the procedure. A quick reminder, you need to be observed in the OR, you need to be observed in clinic. You need 6 of these observations in each area in order to graduate. All right, so get the form, tell the faculty ahead of time. Don't tell them after that, oh, by the way, you just watched me do that procedure. You got to tell them before the case, before you see the patient in clinic, that they're observing you so they can do adequate feedback for you for CAMEOs and INTRAOP evals. Graduation, not only do you need all your cases, your INTRAOP and CAMEOs, but you also need to have taken at some point, not current, ATLS, ACLS. You need to pass FLS, and for next year, you'll need to pass FES. Not the current group of chiefs, but the next group. That's fundamentals of endoscopic surgery. Goals and objectives. There's goals and objectives for every service that you rotate on, for every rotation. You should read them, know what they are ahead of time. You get asked that in your spring reviews. The resident handbook has everything, all this information, plus all additional information. It is rather dry, I understand that, but it is a good reference. They will send it to you electronically, so you have it, so you can say, oh, by the way, what happens, why do I only have so much meal money this year? There's explains in there how meal money is distributed to residents based on call, so that should help. You are responsible for everything that the handbook includes in it, not just what I've mentioned today. So don't be caught in this situation. You don't want to be the captain of a sinking ship. We say everybody is the leader of a ship. You don't want to be standing on the bridge when your feet are getting wet. All right, so if you're an intern, tell someone higher. Even if you're a chief and the patient's not doing well, tell the attending. No attending likes to walk in the morning to find out Mrs. Smith died last night and they didn't hear anything about it. All right, so don't be caught as the captain of the ship. The residency has a rather robust backup plan for anyone that's in trouble. This is the needs help questions about a patient column. So you call your service resident, your service chief, your fellow, the attending. This other column is the, oh my God, I need somebody right at the bedside right now. 6100 is always here. call that pager. They will come right away. 5513 is always here. 5300 is the ICU. If worst comes to worst, you can call the trauma attending. We are usually always here to come to the bedside and help out before your service does. Last but not least, I always have my pager. You can always call me, and I will help you direct you to the right people to call. This is my associate program directors for this coming year. Dr. Humphreys, Dr. Salcedo, Dr. Souter is joining the associate program directors, and that's Leshikar at the end, who's going to join the faculty starting tomorrow as an associate program director. I don't have his pager yet. That's why I didn't list it. But that's the other program directors. That's where I am, still in 4 North. You can make an appointment with Matt if you need to meet with me. Try to condense it down as quick as possible. Thank you. Any questions?